Yeah, so when we look at the low FODMAP diet, it's very important to think of two possible strategies to implement it. We can look at the traditional approach, which would be considered a top-down approach, taking all the high FODMAP foods out of someone's diet for a period of about 6 to 8 weeks traditionally. But also it's important not to think of the FODMAP diet as a single type of intervention. We can also do a bottom-up approach, and that would be very much looking at the individual patient's intake and seeing where the sources of the FODMAPs are generally coming from. If that patient has a desire to have a modified approach, which means it will be easier to implement in the long run and possibly easier in terms of eating out and their quality of life, we would very much do that. And that's working with the individual patient to ensure we can identify the high FODMAP foods in their diet, isolate them from their diet, and then reintroduce to tolerance in the long term to ensure their diet is adequate and has enough of these important prebiotics. So the modified version, if we think about what a low FODMAP diet entails, so it has a very complex acronym, but the acronym stands for fermentable oligosaccharides, disaccharides, monounsaccharides, and polyols. So usually within a modified low FODMAP diet, the largest amount, the most predominant amount of FODMAPs in the diet will be fructans. Fructans will be found in bread products, in onions and in garlic. So usually if you take those things out of the diet, you subtract about 50% of the FODMAPs from someone's intake. So usually that would be the most easy way to implement a modified low FODMAP diet. So we do see a lot of patients with celiac disease, maybe up to 30% of patients have ongoing gut symptomology, bloating, abdominal pain, and maybe diarrheal or constipative type symptoms. In these patients, it's very important to work with the dietitian, but also the consultant gastroenterologist leading that person's care. It may be that person needs to have a repeat biopsy to genuinely understand what's going on with their symptoms. If it transpires that they may be a super sensitive person with celiac disease, then we could instigate maybe a diet that attempts to restrict the gluten in their diet a little bit more. That may be for a temporary period until to see if we see it successful. If someone has ongoing gut symptoms and it transpires they're in what we call mucosal recovery or their gut is healed, then we would look at what we would call a functional gut approach. And that may be regular meals, it may be healthy eating, but it also may be this approach called the low FODMAP diet. Again, tailored to the individual. So group clinics for newly diagnosed patients with celiac disease have now been well established within the UK for a number of years, and there's many centres that use that approach. In Sheffield, where I'm from, we did a non-inferiority study comparing one-to-one clinics with group clinics, and they were similar effectiveness at about a 3-month mark. So both within one-to-one clinics and group sessions, we found that people's serology improved in terms of their anti-endomeasal antibody and tissue transglutaminase, and we also found their quality of life improved in the same way, and their serological in terms of their vitamins and minerals, B12, vitamin D improved. So we think those two approaches are similar, but equally there's an additional benefit to group treatment in that patients get peer-to-peer support, so they're able to discuss their condition and not feel isolated. They see that other people have celiac disease as well. That's why we feel that group clinic can be a very good approach. Certainly within our clinic, my clinic is an adult clinic, celiac clinic, so it does follow really, our clinic seems to follow what we would think would be the current evidence base on the epidemiology of celiac disease, that the vast majority of our patients tend to be between 40 and 60 years of age. There's a slight selection bias maybe in our centre because we have a university population, and I think that influences some of the people that we see in clinic, but I would say predominantly, we see patients that would tie in with the evidence base for the diagnosis of celiac disease in the 4th to the 6th decade of life.